Hello, everyone. My name is Natasha Sheybani, and I'm a postdoctoral fellow at Stanford University, as well as senior scientist at the Focused Ultrasound Foundation. In today's talk, I'll be offering a brief overview of imaging applications in immuno-oncology. So imaging plays a fundamental role in the diagnosis, treatment, and monitoring of cancer. And with the unprecedented outcomes that immunotherapy can offer, there's tremendous interest in leveraging and advancing imaging tools to image the immune system. When we think of imaging, there are several different modalities that come to mind, and these are summarized here on the slide. You can see that the color coding here depicts where these modalities fall on the spectrum, ranging from anatomical to functional information. As a minor caveat, this spectrum is by no means black and white. In fact, new scientific advancements are pushing the boundaries of how we can use more of these modalities for functional imaging at high spatiotemporal resolutions, while advancements in biomedical imaging informatics and data science are enabling us to discover novel imaging biomarkers that can serve as a proxy for molecular signatures in cancer. I'll talk about each of these topics a bit more in forthcoming slides. The table here shows experts' take on the expected advancement of these imaging modalities over the next 5 years. And while parameters like spatial resolution, reproducibility, and system sensitivity are expected to improve, the burden of other factors like examination time and radiation exposure is expected to decrease. And all of these are, of course, positive for the future of advanced imaging. With these advancements, however, it is likely that the system costs will continue to rise. So to recap briefly, there are three noteworthy classes of immunotherapy that bear relevance to this discussion. As they've already been introduced throughout this workshop, I'll just mention that they include immune checkpoint blockade, CAR T-cell therapy, and cancer vaccines. And you can see on this slide illustrations for how reporter probes or contrast agents can interface with each of these therapies. Delving a little deeper, there are three main strategies by which we can perform immunoimaging. Their advantages and disadvantages are listed here on the slide. And the first of these categories is the use of targeted probes for imaging endogenous biomarkers. These can include, for example, antibody-based tracers or directly labeled peptides, ligands, or cytokines, among other things. And we then also have different forms of immune cell labeling. So in the case of direct labeling, cells isolated from a patient are labeled ex vivo with an imaging probe, following which they're adoptively transferred back into the patient. And while this can enable longitudinal monitoring of the labeled cells, there are some noteworthy limitations to this particular approach that I've listed here on the slide. And the final approach, indirect cell labeling, actually helps to overcome some of these aforementioned limitations of direct cell labeling by either transducing or transfecting immune cells with a reporter gene instead. And these reporter gene approaches can be designed to reflect important information like immune cell locations, viability, and even activation state. Collectively, these methods can help us characterize immune topography in different tumor settings. They can help us track immune cell migration and activation over the course of immunotherapy treatment, monitor immune-related toxicities, and most importantly, these imaging tools can help us understand underlying mechanisms in settings where immunotherapies fail. And as we know from the discussion at this workshop, this is a very critical point of discussion and a reason that we're hoping to leverage focused ultrasound in the setting of immuno-oncology. So the labeling strategies that I just mentioned have given way to a wealth of preclinical and clinical immunoimaging paradigms, as in the examples that are shown here on the slide, where really everything from immune checkpoints to activated T cells to myeloid cells have been non-invasively monitored. And you'll notice that the examples shown in this particular slide do include both rodent models as well as some human imaging as well. I'll now spend a brief moment touching on focused ultrasound studies that leverage each of these different strategies, beginning with targeted probes for endogenous biomarkers. Here on this slide, all the examples that I'm showing involve radiolabeling an immune-targeted antibody for spatiotemporal tracking by PET imaging. In the upper left example is some of our work that I was involved in during my time in the Price Lab, where we were evaluating penetrance of a CD47 targeted antibody following FUS BBB opening in gliomas. From Hallie Liu's group and Charles Truliet's groups, we've also seen other examples of FUS-BBB opening in gliomas to potentiate delivery of radio-labeled antibodies targeting VEGF or EGFR, respectively. And across the board, these studies have really been designed to show that FUS can enhance the accumulation of the antibody at the targeted tumor site. And yet another recent work was from Kathy Ferrara's group, where it demonstrated development of a novel CD40 immunoreactive probe applied in pancreatic cancer. In terms of cell labeling methods, I'll just touch on two studies briefly. This one from Amy Heimberger's group sought to monitor EGFR-V3 CAR T cells following FUS-BBB opening in murine gliomas. And this was enabled by modifying the CAR plasmid to express firefly luciferase for bioluminescence imaging in this case. And you can see representative examples of non-sonicated and sonicated mice shown here on the slide. In an example of direct cell labeling, this study from Kalervo-Hinninen's group loaded HER2-directed NK92 cells with superparamagnetic iron oxide nanoparticles to track their accumulation at the site of a breast cancer metastasis model following FUS-BBB opening. And again, you can see representative images shown here where effectively the greater the decrease in signal change, the greater the accumulation of these iron oxide nanoparticles. I also want to make a brief point that images are data, and they can be used at a much deeper level to support clinical decision-making. Indeed, the burgeoning discipline of radiomics applies tools in artificial intelligence to extract quantitative subvisual features from standard of care radiologic images. And some examples of those features are shown here on the slide on the bottom left. Radiomics features can also be integrated with clinical, pathological, or genomic data to yield more sophisticated models as well. And an example of a study using radiomics is actually shown here, where basically this group demonstrated that CT radiomic patterns could predict response to immune checkpoint blockade with traditional anti-PD-1 and anti-PD-L1 therapies in the setting of non-small cell lung cancer. And so this is just one of many different examples that are now trickling into the immuno-oncology literature. And to further that point, I want to mention another phenomenon where imaging tools and advanced analytic approaches can also be used to tool another grand challenge for monitoring of response to immunotherapy. And this is discernment of pseudoprogression from true tumor progression. So here on the slide, you can see, first of all, an illustration of what pseudoprogression is. It basically consists of radiological response pattern where tumor size increase or appearance of a new lesion is observed, but then this is followed by tumor regression. And typically this is a signature that's associated with some sort of ongoing inflammatory response that eventually resolves the tumor itself. But one of the downsides is that pseudoprogression is most often diagnosed retrospectively, which suggests that there's a need for better tools to be able to detect pseudoprogression closer to when it's actually happening. And so I'll draw your attention to a few different examples that I'm showing here on the slide. These are two different examples of this pseudoprogression signature in different metastatic melanoma cases that were treated with immunotherapy. The example on the right, which shows the distinction between contrast MRI and PET signals, and I think this is rather important. Whereas the MRI signal here suggested recurrence, PET imaging actually showed pretty insignificant uptake, which was ultimately consistent with what was confirmed by biopsy, which was basically that there were ongoing treatment-related effects like radiation necrosis and T-cell infiltration that at first glance may have looked like tumor progression. And so these are very important considerations to think about going forward. And just to bring things full circle, pseudoprogression is also a topic of interest to the artificial intelligence community. These are a few different studies that I'm highlighting here where multi-parametric imaging or methods in machine or deep learning are being leveraged to basically enable prediction of pseudoprogression. And as it happens, these papers are all on the example of glioblastoma. So just to conclude, I want to say that imaging is a staple of clinical oncology that facilitates non-invasive longitudinal disease detection and monitoring. There's a diverse toolkit of available imaging modalities and probes that we can use to contextualize immune responses and track response to immunotherapies. And of course, there's continued advancement happening to where imaging will absolutely play a role in facilitating precision immuno-oncology approaches going forward. And with more sensitive and specific imaging techniques, and of course, more data, there will come opportunities to advance robust approaches in artificial intelligence for immunotherapy deployment and monitoring. And with that, I would like to thank you for your attention and look forward to a fruitful discussion to follow.